Good afternoon, everyone. My name is LaShawn, and our group will be presenting our evidence-based practice project on postpartum hemorrhaging prevention and treatment. Postpartum hemorrhaging remains one of the leading causes of maternal morbidity and mortality worldwide. PPH accounts for nearly 11% of maternal deaths in the developing countries, and much higher portion globally. Today, we will be exploring how standardized bundles, quantitative blood loss measurements, and interprofessional readiness can improve our outcome. Now, let's begin by framing the clinical problem and our Peacock question, which guided this project. The problem is clear. Postpartum hemorrhaging is preventable, yet variations in recognition and response leads to a delay in treatment. So our question is, how can we standardize care to improve the outcomes? So our Peacock question begins with population. So it's going to be postpartum patients delivering in a labor delivery unit. The intervention will be standardized postpartum hemorrhaging bundles, which include active management in third stage labor, quantitative blood loss, uretronic readiness, and tiered escalations. The comparison usual care without a standardized bundle or reliance on estimated blood loss. Outcome is to reduce postpartum hemorrhaging by 1,000 mLs and decrease transfusion rates and transfer time to escalation. And we want to improve adherence. And then time. We want to be able to see this within a 6-month post-implementation. Now that we've defined the problem, let's look at what the evidence tells us about prevention and treatment of postpartum hemorrhaging. Now, evidence is constantly supporting active management of third stage labor. Prophylactic uretronics and controlled cord traction significantly reduces postpartum hemorrhaging risk. Now, let's go ahead and look into this further. So, measurement and accuracy matters. So, quantitative blood loss is more reliable than visual estimation, which correlates better to maternal instability. Next, we have bundles and simulation drills, which will help improve adherence and response times, as shown in both high resource and low resource settings. Lastly, we have risk stratification, which tagging patients as low, medium, or high risk guides preparedness, such as placing second IVs or keeping uretronics at the bedside. But despite these strengths, there are still gaps in the evidence that shows how we can implement bundles, which we'll review in the next slide.
Based specifically on the article written by Sheldon, Blum, and Winikoff, the authors outlined several areas where evidence is limited, uncertain, or not completely known yet regarding postpartum hemorrhage prevention and treatment. To start off, Sheldon et al. 2022 states how although active management of third stage labor is an effective prevention for postpartum hemorrhage, specific components of care are not tailored to specific populations. Therefore, there are gaps in knowledge and research on how to individualize prevention strategies based on patient-specific risk factors, since they can vary depending on who is in front of us. Next, oxytocin is a first-line medication for preventing postpartum hemorrhage, but specific dosage, timing, and route for maximum benefits still needs to be studied further. And the current risk assessment tools for postpartum hemorrhage have limited accuracy, meaning women deemed low risk have suffered from life-threatening postpartum hemorrhages. Therefore, reliable mechanisms to identify who will benefit most from preventative interventions have not been well established yet. Continuing on evidence synthesis on what is not yet known, Sheldon et al. Also emphasizes that majority of research regarding causes of postpartum hemorrhage are for uterine atony, which is the leading cause, so it does make sense why there's so much research surrounding it, but this leaves limited research on other causes such as trauma, a retained placenta, and patient coagulation disorders. And research, again, addressing prevention for these causes rather than response is scarce. Next, misoprostol is a common alternative used if oxytocin is not available. As stated in an article written by Evanson et al. 2017, this medication has numerous adverse effects such as nausea, diarrhea, and fever just within a few hours of giving birth. And there's limited research on the long term effects of misoprostol used as the next best preventative agent when oxytocin is not available. And to build on that, um, prevention strategies in low resource settings, such as low resource hospitals in rural areas, is also scarce. Lastly, there is limited evidence on long term outcomes of preventative measures being implemented. Most of the evaluation of long term outcomes are surrounded around short term blood loss, but they have called for a need of further research on the long term outcome of preventative measures being implemented, on how it affects long term maternal health, physiological impact, as well as reproductive outcomes for these women.
Hi everyone, I'm Danielle, and I'll be walking us through the evidence-based practice model that our group selected to guide this PPH project. So far, you've heard about the clinical problem, our Peacock question, and the key evidence around prevention and early recognition of postpartum hemorrhage. The next step is now choosing a model that can actually help us translate all of that evidence into real unit-wide practice change. So for this project, we chose the Iowa model because it's specifically designed for organization level clinical practice changes, which is exactly what a PPH bundle requires. The strength of the Iowa model is its structured stepwise pathway. It guides us from identifying the problem to appraising the evidence, to piloting the intervention, and finally evaluating outcomes. This aligns with our Peacock goal of reducing severe PPH using a consistent evidence based bundle, including active management, qualitative blood loss or QBL, and structured escalation steps. We also considered the Steltler model, which is great for helping individual clinicians use evidence in their own practice. However, because our project requires unit wide adoption and interdisciplinary coordination and clear outcome tracking, we found that the Iowa model provided a better and stronger, more practical framework for implementing a standardized PPH bundle. Now I'll walk through how the Iowa model actually looks when we apply it to a PPH bundle in an labor and delivery unit. We start by identifying the problem. PPH is a major complication and inconsistent practices can delay recognition and treatment. Next, we review the evidence, which supports active management of the third stage, quantitative blood loss, and standardized PPH bundles. The model guides us to bring together an interdisciplinary team to plan the change, like nurses, doctors, staff like that. We then pilot the bundle on the unit for 6 months with staff training and practice drills. Finally, we evaluate whether the change is effective by looking at outcomes like PPH over 1,000 mLs, transfusion rates, time to escalation, and overall how consistently that staff follows the bundle. Overall, these measures help us determine whether the practice change is effective and sustainable for our unit.
Hi, my name is Angelina and I'll be covering the agency readiness assessment. So for the agency readiness assessment, we first looked at the strengths that could support implementing a standardized PPH bundle. One major strength is the strong culture of teamwork in the L&D unit. Nurses, OBs, anesthesia, and postpartum staff already communicate well during handoffs and emergencies, and this is essential for rapid, coordinated response during a hemorrhage. Another strength is that nurses are already familiar with postpartum monitoring, things like fundal checks, vital signs, and early symptom recognition. This makes it easier to integrate structured elements such as QBL and standard escalation. We also noted strong administrative support for quality improvement projects, which helps with resources, training, and protocol adoption. On the other hand, we identified a few barriers. The biggest one is inconsistent use of QBL. Some staff still rely on visual estimation because it feels quicker and more familiar. Another barrier is inconsistent availability of supplies like calibrated drapes, scales, or fully stocked hemorrhage carts, especially during high volume times. We also saw variation in escalation thresholds. We can see that newer nurses may escalate sooner, while experienced nurses may wait a bit and judge it out as they see. And lastly, busy shifts can limit documentation accuracy or timely QBL. These barriers highlight where more structure and support are needed. And this next slide, I'll be looking into mitigation and overall readiness. To address the barriers in the previous slide, we focused on a few targeted mitigation strategies. First, regular simulation drills can help reinforce QBL, medication readiness, communication, and escalation steps. Practicing these scenarios builds confidence and consistency across the team. We also recommend standardizing supplies, ensuring that each room has calibrated drapes, a working scale, and a stocked PPH cart. Reduces delays and helps staff know exactly where everything is during an emergency. Posting laminated escalation algorithms in every room also gives staff quick visual cues during high stress situations and keeps everyone aligned on response thresholds. Another helpful strategy is designating PPH super users on each shift. These trained staff members can coach others in real time, answer questions, and support escalation decisions. Especially valuable. This is especially valuable during maybe like a night shift where fewer resources are available. Overall, with these mitigation steps, the agency shows moderate to high readiness for change. The foundational strengths, which are good teamwork, communication, and administrative support, are already in place. With standardized education and reliable resources, the unit is well positioned to successfully adopt a PPH bundle and improve consistency in recognizing and responding to hemorrhage.
So this is our education plan. Postpartum hemorrhage continues to be a major cause of maternal morbidity and mortality, even in high resource places, because recognition can be delayed and practices vary a lot. So our goal is to teach this standardized postpartum hemorrhage bundle in a way that feels simple and doable. For nursing, the focus would be walking through the bundle step by step, active management of the third stage, using QBL instead of visual estimation, having uterotonics ready at the bedside, and knowing exactly when to escalate. We'd also do quick demos and short skills sessions so nurses feel comfortable using the supplies and documenting correctly. For other health professionals, we'd highlight how the bundle helps everyone communicate faster during a bleed. We'd clarify roles and make sure OB, anesthesia, blood bank, lab, and RT know the escalation triggers and what's expected of them. The evidence shows that standardized communication and clear roles reduce severe hemorrhage, so we connect that to our plan. And then lastly, with administration, we'd keep it simple. Show the evidence, explain the expected improvements, and outline what resources we need to roll out the bundle successfully. This includes staff education time, updated protocols, stock supplies, and support for simulations. We'd also explain our 6 month timeline and outcome measures so leadership knows how we'll track success. So, I will be going over our implementation protocol and algorithm. To begin, our implementation protocol consists of eligibility preparation, active management, QBL steps, and escalation thresholds. For the eligibility, all vaginal and cesarean deliveries, preparation, there's a risk tag, which we have given in Article 4, active management, such as urotonics, administering per guideline immediately after birth, core traction, controlled traction with uterine support, and then our QBL steps include for vaginal, use calibrated drape, weigh pads slash sponges, record cumulative QBL every 15 minutes until stable, and then for cesarean, we would measure the suction canister, and then of course subtract the irrigation, weigh the sponges, maintain cumulative QBL. And then those are our escalation thresholds. And then our algorithm, it consists of risk tag at admission, and then you go to the birth, then you start the QBL, and then you look at the threshold slash instability, and then you reassess.
To evaluate the metrics, We will measure the success through process metrics. So we'll look at the quantitative blood loss documentation rate, bundle adherence, and simulation participation. The outcome metrics would be measured by postpartum hemorrhaging incidents that are 1,000 mLs or more. We'll look at the transfusion rates, time to escalation, and ICU transfers. And we would also look at the equity lens, which stratify outcomes by race, ethnicity, and language, and feedback loop. We would do monthly huddles, dashboards, and to review any discrepancies or areas that need improvement. We've covered evidence, model, readiness, education, and protocols. Now, let's go ahead and close out with a question. Where do you anticipate the greatest barrier to sustain quantitative blood loss and postpartum hemorrhaging bundle adherence in the labor delivery unit? Do you think the breakdown would be with supplies, documentation, team communication, or escalation thresholds? And which single change would most likely or effectively remove that barrier from the night team coverage? We invite your thoughts on balancing evidence-based protocols and local context. We hope you enjoyed our presentation, and thanks for watching.